This is one of the topics that I have been receiving many requests on the channel for me to actually get it done. Currently, I don't have any power, so if the PC goes off midway through the recording, I'm not going to do this again. So I really hope that it lasts through the entire recording. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at sepsis and septic shock. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper and let's go. So there are two things here. So there's sepsis and there's septic shock. Sepsis in itself is a complication of, or rather, septic shock is a complication of sepsis. So remember, shock is just this life-threatening state, which is going to be characterized by this impaired tissue perfusion. There's this disturbed cellular metabolism, and this is going to be affecting the function of the body, which is going to be resulting from a decrease in the oxygen supply. And the very fact that it's caused by many things, it's considered as a clinical syndrome. Whilst when you talk about sepsis, it's just simply this life-threatening organ dysfunction that's going to be caused by a dysregulation to a response to infection. So when you talk about septic shock, it's like a subset of sepsis. It's a severe complication of sepsis. It's actually the most severe or the most serious type of sepsis and the most difficult to treat. Remember the different types of shock that exist. For the body to actually function, three things have to be there in terms of the cardiovascular system and supply of blood and oxygen and nutrients to the tissues. Number one, the heart has to pump very well. So if there's a problem with the pump, they could have a cardiogenic type of shock, for example. Number two, there has to be blood volume that it has to be adequate. So if there's a problem with the blood volume, either through bleeding, which is known as hemorrhagic shock, or the blood volume is being reduced in some way, we call that as hypovolemic shock. Then the third type is the tone of the blood vessels, where our blood vessels could either vasodilate or vasoconstrict. So sometimes the blood vessels could vasodilate, sometimes they could be damaged to the vasculature, leading to blood extravasating and being trapped in the third space, being trapped in the interstitium, being trapped in the extremities. And so this is collectively referred to as a distributive type of shock. Septic shock is predominantly a distributive type of shock, though in the pathophysiology, we do realize that there is some alterations in the capillary permeability and there is some fluid that is lost from the vascular space. So it does have some component of hypovolemia in it. So remember that because of this reduction in the tissue perfusion, it's going to be affecting the lungs, it's going to be affecting the kidneys, it's going to be affecting the liver. So it can actually result in multiple organ failure. So one key thing to keep in note is that sepsis is actually a progression of things. So there's going to be a progression of this dysregulation to infection, something that's known as a systemic inflammatory response syndrome, or SARS. We'll talk about it in details, and it's going to end up in multiple organ dysfunction or MODS. Eventually, if this person has multiple organ dysfunction and a lot of derangements that are happening in the body, ultimately this patient is going to die. So one definition that we can keep in mind for septic shock is that if someone has persistent hypotension, which by many literature, they do put it at a benchmark of blood pressure of less than 90/60. But if they have persistent hypotension in one of these things, then we can consider them as to have septic shock. Number one, if they need vasopressors like epinephrine to maintain their mean arterial pressure greater than 65 millimeters of mercury. Remember, mean arterial pressure is largely dependent on the systolic blood pressure. It's largely dependent on the diastolic blood pressure. The second definition is if they have persistent hypotension and a serum lactate level that is greater than 2 millimoles or greater than 18 milligrams per deciliter, despite you having adequately resuscitated them. Because remember that this lactic acid is largely coming from anaerobic respiration that's going to be there because you're not delivering oxygen to these tissues because there's a problem with the supply of blood. There's a problem with the vasculature itself. there's a maldistribution or shunting of blood. So this is going to lead to anaerobic respiration and accumulation of this lactic acid. Remember that this lactic acid accumulation could actually be used to judge prognosis as a poor prognostic factor if you get a high level of lactic acid or serum lactate in these individuals that have septic shock. Then the third definition is if you have a persistent hypotension despite adequate fluid resuscitation from 60 mils per kg to 80 mils per kg of either crystalloid or colloid. So if someone still remains hypotensive despite you giving them 60 mils per kg body weight of fluid in its stipulated time, we'll talk about that in management, we say that this person is in septic shock. So those are the three definitions I want you to keep in mind. Then when we talk about sepsis, the clinical definition of sepsis is just simply SARS, which I'll talk about SARS very shortly, and the focus of infection. The focus of infection could come from many systems. It could come from the GIT, it could come from the respiratory system, which are very common. It could come from a cellulitis, it would come from the genitourinary system. Many things can introduce the infection into the body. So as long as you have a systemic inflammatory response syndrome plus a focus of infection, a proven focus of infection, then we say that this person has sepsis. Then the complication of sepsis is what we refer to as septic shock. So remember that SARS is going to be defined by these certain abnormalities that we see in the vital signs, abnormalities that we see in the laboratory results. And it's been used by many people to identify early sepsis, but the criteria itself lacks sensitivity and specificity in terms of judging those patients that have increased mortality. There's a much better criteria, which is known as the SOFA score. I'll talk about that. That is used to judge mortality risk. So what is this sepsis criteria that I've been talking about? So number one, you want to prove that there is a focus of infection. So you need some evidence of the infection, whether through getting a positive blood culture or maybe this patient has had refractory hypotension. Despite you giving them adequate fluid resuscitation, they still remain hypotensive, plus one of the following things. They meet the criteria for SARS. And for them to meet the criteria for SARS, they must have two of the following parameters. It's either they'll be tachypnic, meaning their respiratory rate is greater than 20 breaths per minute. They'll either be leukopenic, meaning that their white blood cell count absolute value is less than 4,000, or leukocytosis, where their white blood cell count is greater than 12,000. It may be with or without bandemia of more than 10%. Then they can either be having a fever, a temperature greater than 38, or hypothermia, a temperature less than 36. They could be tachycardic with a resting heart rate greater than 90 beats per minute, or they could have arterial blood gases, that's a partial pressure of carbon dioxide less than 32. So if they have any of these two parameters and they have a proven focus of infection, then we say that this person has sepsis. Now, there are some other scoring systems. One important scoring system is known as the SOFA score. SOFA just simply stands for Sequential Organ Failure Assessment Score. And we actually use these because they are a very good indicator of mortality risk, and they're relatively simple to use. There's even a much more simplified version, which doesn't require you to have a lot of labs. For example, if you're trapped in the bush somewhere and your laboratory services are not so good, we can use what is known as a quick SOFA score. So when we talk about the quick SOFA score, it's going to be just having three parameters. It's going to have the blood pressure, it's going to have the respiratory rate, it's going to have the Glasgow Coma Scale. You don't need to wait for the results. So you give them a point for each of the parameters, and the higher the points, it means that the worse the prognosis, the longer the hospital stay, even in the ICU. So remember that for the patients with suspected infections who are not in the intensive care unit, the quick SOFA score actually is a better predictor of inpatient mortality than we see with the systemic inflammatory response syndrome criteria, as well as the SOFA score. Then remember that the SOFA score is much more robust, as I'll tell you about how it's done and how we do the scoring system, and it also requires a lot of lab tests. So if you don't have those lab facilities, it becomes very difficult for you to do the SOFA score. So remember that the SOFA score is going to be useful in predicting the clinical outcomes of these critically ill patients. So I'll begin with the quick SOFA score, which is the quick sequential organ failure assessment criteria. So there are three parameters. It's either your respiratory rate will be greater than or equal to 22, if you have altered mentation, meaning a low GCS, or if you have a systolic blood pressure less than or equal to 100 millimeters of mercury. You give them a score of 1 if they have each of these parameters. The lowest score you can get is 0. The highest score you can get is 3. So anyone who gets a score of 2 or more it means that at the beginning of the infection, it would mean that they had a great risk of death and they had a great risk of staying much longer in the ICU. Then coming to the SOFA score, this is going to be involving different parameters according to different systems, the main systems that are often affected by sepsis. So you have the central nervous system there, you have the cardiovascular system, we have the respiratory system, we have the coagulation system, we have the liver, and we have the renal function. So in the CNS, of course, the parameter that we're focusing on is the Glasgow Coma Scale. As you can see, each of these parameters has a certain score. 15, you give them a score of 0. 13 to 14, you give them a score of 1, so on and so forth. This part is self-explanatory. Then the cardiovascular system uses either the mean arterial pressure or the administration of vasopressors, those that require vasopressors. So if the mean arterial pressure is equal or greater than 70, 0. If it's less than 70, 1. And then if they are on dopamine, that's less than 5 micrograms per kg per minute, or dobutamine, any dose, dobutamine, any dose, you give them a score of 2. Then if they are on dopamine, more than 5 micrograms per kg per minute, or epinephrine less than 0.1 micrograms per kg per minute, or no epinephrine less than 0.1 micrograms per kg per minute, give them a score of 3. Same thing, self-explanatory for this bit. I think you should be able to understand. Then with the respiratory system here, we look at the ratio of the arterial partial pressure of carbon dioxide divided by the fraction of inspired oxygen. So if it's greater than 400, if you're using millimeters of mercury, or if you're using kilopascal, 53.3, you give them a score of 0. Again, this is self-explanatory. If they are mechanically ventilated, including CPAP, and the ratio is less than 200 millimeters of mercury, or if it's in kilopascals, less than 26.7, you give them a score of 3. Then in terms of coagulation, we focus on the platelets. If the platelet count is equal or greater than 150,000, you give them a score of 0. If it's less than 150,000, give them a score of 1. If it's less than 100,000, 50,000, less than 20,000, you give them a score of 4. So again, this is self-explanatory. In terms of the liver, we look at the bilirubin levels. We can either measure them in milligrams per deciliter or micromoles per liter. If it's less than 1.2 milligrams per deciliter, we give them a score of 0. It's less than 20 micromoles per liter, we give them a score of 0. Again, this should be self-explanatory. No one is going to actually ask you to memorize this. They may ask you what parameters do we look for on the specific SOFA score, but no one's going to tell you to actually memorize this whole table. You should just be able to know the parameters that are on this score. Then the renal function test, we have our creatinine there in milligrams per deciliter or micromoles per liter. We could use the urine output. I think this should be self-explanatory. So looking at this table, you grade them and you add the score. So there are some times where you get physiological parameters that are not matching anything that you see on this table. If it's not matching anything that you see on this table, you give them a score of 0. And then sometimes you may be in a case such that you have 2 parameters in the same patient, one with a higher score. For example, you see a patient, assess the level of consciousness, and you find out that maybe the level of consciousness is 13. And then again, a few minutes later, you assess the level of consciousness. So a few hours later, you assess the level of consciousness, and now it has dropped down to 9. During the same period, this person has 2 different readings. You're going to be going for the one that has a higher score. So meaning that you're going to go with the 9, for lack of better examples. That's how I can explain this. So the score is going to be ranging from 0, which is the best score you'd want to have, to 24, which is the worst score that you can have. So in 2019, there was the Survival Sepsis campaign, and actually they advocated for a bundle of these medical interventions to be instituted in the first 1 hour, the golden 1 hour of patients that are septic. So this is in an attempt to actually reduce the mortality and for us to actually identify these patients quick enough and intervene quick enough, because if we place the interventions as quick as possible, it reduces the risk of patients dying. The golden hour is 1 hour. You should do all these things in 1 hour. If by 6 hours you haven't done any of these things, there's a high chance that your patients will not survive. So you want to administer oxygenation or administer oxygen. We'll talk about it in details. You want to collect some cultures before starting antibiotics. Collect your blood cultures before starting antibiotics. You want to start them on a broad spectrum antibiotic. Then once you get your culture results, you can narrow it down to what is actually sensitive. You want to measure the levels of lactate because, again, this is a poor prognostic factor if the lactate levels do remain markedly elevated. You want to monitor your urine output. Remember, a good urine output is a good indicator of good renal function. And remember, the kidneys do suffer when a patient is in shock. Then you also want to rapidly give crystalloids if they are hypotensive or if their lactate is greater than or equal to 4 millimoles. And you want to give them some vasopressors like epinephrine if they are still hypotensive after adequate crystalloid administration. Now, what exactly can cause sepsis or septic shock? Most of the infections are going to be gram-negative bacteria. Remember that we have largely two types of bacteria, gram-negatives and gram-positive. The difference is this. Gram-negatives, they have a thin cell wall, which has very minimal amounts of peptidoglycan. In addition to this, they have another component which is found in their cell wall on the outer aspect, which is known as the lipopolysaccharides. It is these lipopolysaccharides that have been implicated in the pathogenesis of sepsis. On the other end of the spectrum, the gram-positives usually have a thick cell wall with a lot of peptidoglycan layer. And of course, these ones are going to be producing a special type of toxin, which is known as an exotoxin. On the other end, the gram-negatives are going to be producing an endotoxin. Remember, for the endotoxins to be produced, the gram-negative bacteria actually has to be killed. On the other end of the spectrum, from the gram-positives that are producing the exotoxins, the bacteria may not even be there, but it may cause you illness if it has produced the toxin and even died long ago. That's the case of what we see in food poisoning. So remember that most of these are going to be caused by hospital-acquired gram-negative bacilli or gram-positive cocci, and they are much more common in immunocompromised patients. They are much more common in patients with chronic debilitating diseases. So remember, there is an incidence of gram-positive infections that's on the rise, and we may attribute this to maybe there are more invasive procedures that are being done in the hospital these days, and of course there's an increase in the incidence of nosocomial infection. Maybe this calls for a need to improve on our infection prevention techniques. And some predominant microorganisms that are often implicated are things like Staphylococcus aureus, about 20%, Pseudomonas, about 20%, Escherichia coli, about 16%, and generally they affect sites like the respiratory system, very common. They could be found in the bloodstream, they could be found in the biliary and the gastrointestinal tract, sometimes they could be found in the genitourinary tract. It was also sometimes important to remember that sometimes even some non-bacterial species like fungi can cause sepsis. And this is very common, especially in the immunocompromised, to the fact that if you're already treating a patient that is immunocompromised that you're suspecting to have sepsis, it's better to actually add an antifungal agent that is going to be empirically treating this patient, because this patient could have fungal-related sepsis. So there is some growing concerns, especially in our hospital, and we have seen this, and it's quite threatening and it's quite dangerous. We're getting patients that we are treating and not responding to our antibiotics. And when we get the culture results, we realize that they're resistant to almost everything. I once saw a resistant result of a patient that was resistant to almost everything except levofloxacin. And these are the bugs that are circulating around. So there's a big problem with the resistant strains of bacteria, especially those multi-drug resistant strains, like, for example, the methicillin-resistant Staphylococcus aureus or the MRSA, or the vancomycin-resistant enterococci, the VRE. Sometimes you may have this in sepsis or this septic shock presenting after a post-operative or surgery. So whenever you are suspecting this, then if someone has a post-operative infection, then you should suspect that this is a cause of the septic shock. In some cases, there is a unique type of shock which is caused by staphylococcal or sometimes streptococcal toxins, which is known as toxic shock syndrome. It was very common, especially with patients that used to have those tampons where you insert into the vagina, or you have those menstrual cups that often would remain and be kept for a very long period of time. So what are some of the risk factors that are seen? So you may have things like diabetes, malignancies, chronic kidney disease. You may have chronic liver disease, cirrhosis, use of corticosteroids, which tend to impair the immune system, inappropriate use of antibiotics, because this can culture resistance. You may have immunosuppressed states like cancers, treatments with cytotoxic medications that can cause leukopenia, burns because the integrity of the skin is gone, major surgeries, trauma, sometimes invasive devices like endotracheal tubes, vascular or even urinary catheters, drain tubes, and even other foreign materials You may have prolonged hospitalization, especially in those patients that stay in the intensive care unit for a very long time. They are predisposed to a lot of these organisms, and most of them that hang around in the hospital tend to be quite resistant. You may have patients that are on hemodialysis, the extremes of ages, such as neonates and older people, as well as pregnant women. Now, what exactly is a pathophysiology? I love it when people say that the pathophysiology is not so understood. Then you go ahead and explain pages and pages of the pathophysiology. But anyways, we're going to do that right now. So remember that this patient has an infection. Whenever they have an infection, a focus of infection that spreads now into the body, actively multiplies, and starts to cause this reaction from the immune system that is dysregulated, then the patient actually goes into septic shock. So remember that this septic shock is going to start off as maldistribution of blood. Then this is going to follow myocardial depression. This is also going to be characterized by hypovolemia. So there may be an inflammatory stimulus that is there, either a bacterial toxins. Remember when we talked about the endotoxins, which are lipopolysaccharides that are found in the gram-negative organisms. When the gram-negative organism now infects your body, it gets broken down and it releases this lipopolysaccharide proteins. These lipopolysaccharide proteins can then bind to the lipopolysaccharide binding protein and form a complex. It is this complex that can actually trigger the immune system and trigger the production of these pro-inflammatory markers such as tumor necrosis factor alpha, such as interleukin-1. And remember, what are these inflammatory markers going to be doing? They're going to be causing neutrophils to actually adhere to the endothelium, to start sticking to the endothelium. They're going to activate the clotting proteins. They're going to cause microthrombi to actually form. There are also another numerous mediators of inflammation that are released. So things like leukotrienes, things like lipoxygenase, which is part of those reactions that are involving arachidonic acid, converting them into prostaglandins and leukotrienes. You may have production of things like histamine, bradykinin, serotonin, interleukin-2. And remember that there is normally a balance in the body between the pro-inflammatory mediators and the ones that are anti-inflammatory. So some anti-inflammatory mediators are things like interleukin-4 and interleukin-10, which have a negative feedback. But remember that this person has sepsis, and they're having this dysregulated response to the infection. So initially, your arteries are going to, and the arterioles are going to dilate. And remember that the tone of the arterioles, which are the resistance vessels, are pretty much going to be offering the peripheral resistance in the cardiovascular system. If they dilate, so it means that the peripheral resistance is going to decrease. But remember that if the peripheral resistance decreases, there's a normal reflex of the heart to beat faster to compensate so that your blood pressure doesn't drop. Remember that blood pressure is a product of cardiac output times total peripheral resistance. Cardiac output is a product of stroke volume times heart rate. You don't really change much of your stroke volume in this phase, but you're going to be changing your heart rate because of this reflex tachycardia that is going to be there. So this person, when you feel the extremities, they're going to appear warm and their cardiac output will be increased. So you refer to this stage as warm shock. It's usually the early stage of septic shock. So clinically, these patients are going to be having a dynamic precordium. They're going to be tachycardic, they're going to have a bounding pulse, they're going to be warm to touch, and of course, there's going to be a reduction in the capillary refill or a delay in the capillary refill time. Then later on, the cardiac output is eventually going to decrease. That reflex can only compensate to a certain extent. Once this now begins to decrease, remember, cardiac output multiplied by the total peripheral resistance equals to the blood pressure. So the total peripheral resistance decreased because there was this initial vasodilatation that was there. Cardiac output now is beginning to fall because now the heart rate is also beginning to decrease. So this may sometimes be associated with an increase in peripheral resistance. Sometimes it may not, but ultimately the blood pressure is going to fall and this patient is now going to develop these typical features of hypotension. Remember now, when there is hypotension, it means you're not taking blood to the tissues which need these oxygen, they need the nutrients, and they need waste materials to be carried away from them. So when the demands are not met and oxygenation is not done properly, then the patient enters into a stage that's known as severe sepsis. So as you have this decline in this oxygen that is supposed to be provided for cellular metabolism, remember that cells are now going to be respiring anaerobically. And remember, anaerobic respiration results in the production of lactic acid. It also results in production of less ATP. So even though sodium potassium ATPase pumps are going to be working less, and you get a lot of accumulation of this lactic acid, even the pH of the blood may actually begin to reduce. So eventually, even in this stage, even in the stage of increase in the cardiac output, rather, in the very first stage, you do get the vasoactive mediators being released. And these vasoactive mediators are very important because they allow shunting of blood past capillaries. Remember, this shunting of blood also worsens the hypoxia. So you call this as a distributive effect. So remember, as the shock is going to be progressing, the catecholamines that are going to be produced are going to lead to an increase in peripheral resistance and shunting blood away from certain organs. So blood is shunted from the non-vital organs like the GIT, the kidneys, the muscles, the skin, and they're shunting it to the organs that are what I like to call selfish organs, the brain and the heart. So at this point now, the skin becomes cold, it becomes clammy, and this person is in a stage which is known as cold shock, which is the late stage. So with the poor capillary blood flow that's going to be there, the shunting with the capillary obstruction that's going to be there because of these microthrombi that are forming in the capillaries, there's going to be decrease in oxygen delivery, there's going to be impairment of the removal of the waste materials and carbon dioxide. So as the kidneys are being underperfused, they may begin to fail. So it means that if this is affecting one of the kidneys or both of the kidneys, this patient may result in pre-renal azotemia or pre-renal acute kidney injury. It may affect the lungs, it may affect the liver, resulting in a transaminitis. It may cause problems in the brain, it may cause problems in the heart. And sometimes there may be a coagulopathy that may develop because you have this intravascular coagulation that is happening. A lot of these microthrombi forming around the body, and they tend to use up all the clotting factors. Sometimes you may have excessive fibrinolysis that is happening. Sometimes it may be a combination of both. So what exactly are the clinical features that we see? So this patient may be in the early stage, which is known as the warm septic shock or the hyperdynamic stage. This one is very difficult to diagnose because we know that typically the different types of shocks, the peripheries tend to be cold and clammy. But in this case, the peripheries are actually warm. So you actually need a high index of suspicion to actually detect this quite early. So the patient will be often restless, they will be confused, the skin will be flushed, it may be warm and dry, and their vitals, they may have a fever greater than 38 degrees Celsius, they may have chills, they may have a mild decrease in the arterial blood pressure, and the pulse pressure may be wide with a low diastolic blood pressure. They may have tachycardia, tachypnea, and a high cardiac output. Then in terms of the late phase or the cold or the hypodynamic stage, here they're going to have a picture that is quite similar to hypovolemic shock. So there'll be a reduction in the cardiac output, the skin will be cold and clammy, their blood pressure, systolic blood pressure will be less than 90, they'll have tachycardia, they may have tachypnea, they may have oliguria, and eventually multiple organ failure is going to set in, and that's what's often going to kill these patients. What investigations would you do? So you want to get a full blood count with a differential. You want to get culture the source, be it blood, get blood cultures, get urine cultures, get cultures of the trachea, or if they're intubated, get cultures of the wound if there's any discharge coming from the wound. You should have at least 2 sets of blood cultures that are recommended before you actually start antibiotics, and all these must be done within 1 hour. And even though we do collect blood cultures, only about 40% of them actually come back positive. Other things that you must do include a urinalysis, urine microscopy culture and sensitivity as well, liver function tests, liver enzymes, urea and electrolytes, creatinine, serum, lactate levels, arterial blood gases, and a coagulation profile. Other investigations may largely depend on the presenting symptoms. They may largely present on the age. For example, if a patient is presenting with features of encephalitis or meningitis, so it's a febrile pediatric patient under the age of 6, you would want to do a lumbar puncture. You may also do C-reactive protein or procalcitonin, which are both acute phase reactants and are actually very helpful in distinguishing between viral as well as bacterial sepsis. And in terms of procalcitonin, it's actually can be used to determine whether this is viral or bacterial sepsis because it's going to be showing a much steeper elevation of the 2 proteins. You may also get a chest x-ray that may review a pneumonia or an acute respiratory distress syndrome. And remember, the plain x-rays of the extremities can show you things like gas in the tissues that may be indicative of necrotizing fasciitis. There may be an ultrasound that you can do to evaluate the gallbladder. You may get a CT scan to assess for any abdominal abscesses, any bowel perforations, which you can also pick up on the CT scan. or signs of ischemia. Some common findings in severe sepsis include hypoglycemia, a glucose more than 6.7 in this case, leukocytosis or leukopenia, that's a white blood cell greater than 12 or one that's less than 4,000, respectively, bandemia greater than 10%, a C-reactive protein or procalcitonin that's more than 2 standard deviations above the normal, if you get a mixed venous saturation of more than 70%, a ratio of the partial pressure of oxygen to the fraction of inspired oxygen, less than 300, pre-renal azotemia, coagulopathy, where the INR is more than 1.5, or the PTT is more than 60 seconds, thrombocytopenia with a platelet less than 100,000, hyperbilirubinemia, that's a total bilirubin more than 4 milligrams per deciliter, lactic acidosis of more than 2 millimoles per liter. As you can see, some of these parameters are actually present in our SOFA score that we discussed earlier on. Our differential diagnosis includes things like acute respiratory distress syndrome, disseminated intravascular coagulation, other types of distributive shock, hemorrhagic shock, adrenal crisis, which is very common with TB. You may have cardiogenic shock, toxic shock syndrome. You may have the drug toxicity. How do we manage these patients? Remember, patients with septic shock, ideally you don't want to manage them on your ward. You want to put them in an ICU. If you don't have this, use a high dependency ward or a resuscitation ward. So you're going to be managing these patients and doing the following things. And remember, these things must all be instituted within the first hour, the golden 1 hour. The perfusion restoration with IV fluids, and sometimes we may use vasopressors like epinephrine, sometimes even no epinephrine. Number 2, you want to oxygenate this patient, give them oxygen support. Number 3, start them on broad spectrum antibiotics. Number 4, you control the source of the infection. And number 5, there are some other supportive measures that we'll talk about, such as corticosteroids and insulin, though there is some controversy in terms of corticosteroids. How do we monitor this patient? So ideally, it should be as frequent as possible, but if we can do it, we should do it hourly. And these patients are usually monitored hourly. We should monitor the volume status by checking their central venous pressure, or you can check their pulmonary artery occlusion pressure, or do serial ultrasound and or central venous oxygenation saturations. Arterial blood gases are very important in sepsis patients. Blood glucose, lactate levels, electrolyte levels, check the renal function. Remember that urine output is a very good indicator of renal perfusion, like I said earlier on. So you should check whether they're passing urine and measure the urine output. Though, again, remember, inserting a catheter into this patient introduces a source of infection. So you can do this only if you can't avoid but catheterizing the patient. And the onset of oliguria, which is urine output less than 0.5 mils per kg per hour, or if they have anuria or if they have rising levels of creatinine, this is going to be signaling that there is impending renal failure. Arterial oxygen saturation is going to be monitored continuously using our pulse oximetry. So we'll begin with the first principle, which is perfusion restoration. So all the measures are going to be effective if you institute them in the first 6 hours. Like I told you, if you don't do everything that you're going to do within 6 hours, you don't give adequate fluids within 6 hours, you fall behind, the risk of your patient surviving lessens. The first step that we're going to be taking is giving this patient IV fluids. Now, there's a big debate on which IV fluid is going to be better for which patients, be it between Ringer's lactate and normal saline. I'm not going to enter into that debate. You can actually comment in the section below if you have reached this far and tell us what the literature is saying about which IV fluid is better for in terms of septic shock, if it's normal saline or Ringer's lactate. But either way, you should use a balanced isotonic crystalloid, and the type of fluid actually has very little bearing on the outcome. But the key thing that you must do is maintain adequate perfusion pressure, because the organs are dependent on this adequate perfusion pressure. If the perfusion pressure is less, if the mean arterial pressure is less, organs are not receiving their blood. So you want to aim to get a mean arterial pressure of at least greater than 65 millimeters of mercury. Some clinicians do decide to add albumin to the initial fluid bolus in patients that have severe septic shock or those that have severe sepsis, though it's a bit more expensive than the crystalloids, but it's generally a safe option and a complement to the crystalloids. So how are we going to give the fluids? So we can give our normal saline or albumin or sometimes even colloid like blood products. We can give up to 60 mils per kg. So meaning that if a person is weighing 50 kg, 50 multiplied by 80 That's the total amount of fluids that you can give. But I don't want you to actually memorize this and keep this figure in your mind, because the goal is not to administer a specific volume of fluid, because you should highly individualize this fluid administration in the patients. Monitor the response of the patient. So what you're aiming to do is you want to aim to achieve tissue perfusion without you actually causing problems for this patient, like fluid overload that can lead to pulmonary edema. So generally, when most patients come in, we give them 1 liter of crystalloids to run rapidly. And most patients actually require a minimum of about 30 mL per kg in the first 4 to 6 hours. The actual quantity of how much they receive in about 4 to 12 hours can actually even be greatly more than their normal body volume. So patients do receive even up to 10 liters of IV fluids. So what are the things that you're aiming for? Number 1, you're aiming for a central venous pressure that's between 8 to 12. Number 2, you're aiming for a mean arterial pressure that's greater than 65. Number 3, you're aiming for the lactate clearance target of about 10 to 20% over 6 to 8 hours. And number 4, you're aiming to have a superior vena cava saturation of about 70% or a mixed venous saturation of 65%. Remember that there is a risk of pulmonary edema, and we do control this by optimizing the preload. So the fluids are often given until your central venous pressure actually is at 8 millimeters of water or 10 centimeters of 8 millimeters of mercury rather, or 10 centimeters of water. Now, this is done so that you don't overload. You don't keep giving this person fluid because their BPs are low. Or the pulmonary arterial occlusion pressure that's reaching between 12 to 15. However, some patients that are having this mechanical ventilation, remember the pressures in the thorax are much higher. They may actually require higher levels of central venous pressure that you're going to reach before you term that this is enough of the fluids that you have given. Remember that the pulmonary artery occlusion pressure or echocardiograph can be done to identify any limitations in the left ventricular function or any incipient pulmonary edema that may occur due to fluid overload. If now you have given the fluid and the fluid are not working, then first-line vasoactive thing that you're going to be using is, of course, epinephrine in cold shock. If it's warm shock, if it's at very early stages, you can actually use norepinephrine. When you have given them fluid and it's refractory, it's not working, they still remain persistently low. Those targets you were aiming for are not reached. Dopamine, way before, used to be a first agent. We used to use dopamine way back, but the guidelines changed. Dopamine is no longer the first line in septic shock. Why? Because dopamine has this inhibitory effect on the hypothalamic pituitary adrenal axis, and actually it affects prolactin and growth hormone, and this can actually cause some sort of immune dysfunction. So epinephrine is going to be the drug of choice, but remember that epinephrine causes vasoconstriction at higher doses, and it may actually even cause organ hypoperfusion and acidosis. One of the side effects, if it's used prolonged for high doses, it may actually extravasate, especially if it's given from the peripheral vessels. It can cause necrosis of the extremities, especially the digits. So often we give it in a central vein. Then epinephrine is going to be indicated to raise the BP if the mean arterial pressure in these adults with hypotension that is associated with septic shock. So remember that our recommended dose is about 0.05 to 2 micrograms per kg per minute, and we give it as an infusion, and we want to titrate and slowly increase the dose until the mean arterial pressure is greater than 65. How do we adjust this? We increase by increments of about 0.05 to 0.2 micrograms per kg per minute. So we can increase over 10 to 15 minutes. If a patient has remained hemodynamically stable, we may actually begin to wean them off the epinephrine because you don't want to keep them too long on it. So we wean them every 30 minutes over the next 12 to 24 hours. And remember that when you're making the solution, it's compatible with dextrose 5%, dextrose 10%, dextrose ringers, dextrose saline, normal saline, ringers lactate. And remember, when you're preparing the infusion, we often dilute the epinephrine in the D5 or D5W in sodium chloride. Remember, we generally tend to avoid using normal saline on its own. If they have a low hematocrit, then we may transfuse them with packed cells or whole blood if those are available. Make sure that these patients are put on oxygen support, so you can do this via face mask or nasal prongs. There's oxygen delivery systems that I talked about that I'll leave tagged at the end of this video. Then, of course, tracheointubation and mechanical ventilation may be needed for subsequent respiratory failure. The next thing is the antibiotics. Remember, we want to start these as early as possible. But before we start the antibiotics, we want to collect the cultures. So this must be started within 1 hour of you making the diagnosis. The antibiotics must be parenteral, so you can't give oral antibiotics, give them IV. And then, of course, this must be done as soon as you've collected all the specimens that you're taking for gram stain and for the culture. Now, you don't just give any antibiotic that you want or any antibiotic that you feel like giving. We often make an educated guess based on the clinical scenario. For example, if this patient has a pneumonia, we know the bugs that commonly cause pneumonia. If this patient presents to you with a UTI, we know the bugs that commonly cause the UTI. Sometimes it's based on the knowledge or suspicion of the causative organism or the sensitivity patterns. If someone has done a research at your facilities, they've swabbed the areas in the hospital and they know that in our hospital we have these bugs that are common, we can actually target patients that have these hospital-acquired infections with these antibiotics as we wait for the culture results. And like I said, we do cover for broad-spectrum gram-positive and gram-negative bacterial agents, and for the immunocompromised, we give them an empirical antifungal medication. So in general, we can common antibiotics that are for empirical gram-positive coverage are things like vancomycin and linezolid, but of course these drugs are very expensive. They're not going to be found in most of our setups. Then for the gram-negative coverage, we often use broad-spectrum penicillins like piperacin, tazobactam, which is available, but it's also quite expensive. Third or fourth generation cephalosporins, ceftriaxone in combination with sulbactam is what I've seen being used commonly, imipenems, and even aminoglycosides. So remember that initially, we want to start off with broad-spectrum antibiotics, then we narrow it down to based on the results of the culture and sensitivity. Then the next thing is to control the source. Remember, if there's an IV or urinary catheters or endotracheal tubes, you remove them if they are not necessary or have them changed. If it's an abscess, you should drain that abscess. If there's necrotic tissue and is devitalized, for example, a gangrenous gallbladder and a necrotized soft tissue, you must remove those things surgically. If the surgical excision is not possible because this patient has these comorbidities or they are hemodynamically unstable to go to theater, then you must put a surgical drain of some sort that may help. And remember, if the source is not controlled, even if you're putting this patient on the antibiotic that is targeting this organism, then they won't work. It won't work. The patient will still keep deteriorating, so you must remove the source. Then in terms of other supportive measures, we do want to monitor the blood glucose and keep it normal, because remember that this improves the outcome of critically ill patients, even in those that are not diabetic, but this is because hyperglycemia tends to impair the immune response. So we can often put them on a continuous IV infusion of insulin, starting at 1 to 4 units per hour, titrated to a glucose concentration that's between 7.7 to 9.9. This approach actually is going to be needing frequent assessments where you're checking the blood glucose at least 1 to 4 hourly. Corticosteroids are a bit controversial. Sometimes we do give corticosteroids like hydrocortisone, less than 400 milligrams IV in divided doses, and often we give this to patients with adrenal insufficiency. In our case, very common with TB, and those that have a documented cortisol testing. Though in some patients that have refractory septic shock, where the systolic blood pressure is less than 90 for more than 1 hour following adequate fluid resuscitation and even vasopressor administration, attainment of the source control, and even putting them on antibiotics that are adequate, there is no need for you to do the cortisol testing before you start them on corticosteroids. You can actually start them on corticosteroids. Then, of course, we prefer hydrocortisone as compared to dexamethasone. I want you guys to actually comment in the section below why we prefer this over that. Then, of course, we continue the treatment based on the patient's response. We can add vasopressin if this patient still has vasoactive refractory shock. And remember, patients with sepsis have high metabolism and thus prolonged starvation should be avoided. So feed them as early as possible. And it has been noted that early nutrition can actually promote gut mucosa and actually prevent the translocation of these organisms from the gut into the circulation. Prevent DVT and pressure sores by giving them aspirin, 75 milligrams once a day, or clopidogrel if they're allergic to aspirin. You can cover them on proton pump inhibitors like omeprazole at 20 milligrams twice a day, for example, to prevent any stress ulcers. Complications include acute respiratory distress syndrome, acute or chronic renal failure, disseminated intravascular coagulation, mesenteric ischemia, liver failure, myocardial dysfunction, and multiple organ failure. In terms of prognosis, it largely depends on the patient's age, any associated comorbidities, the renal function, the need for dialysis, if they require mechanical ventilation, and the response to treatment. Generally, the mortality rates were higher back then, before the sepsis campaign and before institution of these sepsis bundles and a lot of these measures and before advancements of medicine. So, but now the mortality rates are a bit less as compared to a few years ago. So they may range from 10 to 20% depending on the patient's characteristic, but average is about 30 to 40%. The poor outcome often follow failure to institute the early aggressive therapy. Like I said, within 6 hours of the suspected diagnosis, if you don't do what you're supposed to do, your patient is most likely going to die. And once the lactic acidosis with decompensated metabolic acidosis becomes established, then there's going to be this multiple organ failure, and these patients with septic shock are likely to be at a stage which is irreversible and they are likely to die. I really hope you enjoyed this lecture and understood and it shed more light on septic shock. I will do another video talking about the adrenaline infusion and how we can make the adjustments with practical examples in another video. If you really want that video, comment in the section below. But for now, my name is Dr. Moses Kazevu. Until next time, bye-bye.